you. Thank you. Good morning, board members. This is a meeting of the Joint Public Health Board. The first item on our agenda today is election of chairman. That chairmanship will come for this meeting from a representative of Dorset Council's side. Ordinarily, there's two members. We have here Councillor Laura Miller. We will be joined later by Councillor Graham Carr-Jones, but on the basis that Councillor Miller is the only member here from Dorset Council at the moment, one would assume, one would believe that she would assume chairmanship.
Thank you. If everyone's comfortable with that, I'm delighted to have been selected out of such a wide and dignified field. So thank you for that.
Happy to second that assumption.
Second.
And moving on then in the agenda to the appointment of vice chair. Aaron, would you like to be nominated?
I would like to nominate Councillor Nicola Green.
I would like to second that. So Nicola, thank you.
Thank you, Aaron.
Right. Apologies for absence. I have an apology for the first bit of absence, which is from Councillor Graham Carr-Jones. And it also includes an apology from me because Dorset Council had an unavoidable clash where Cabinet is actually meeting informally this morning, and that's why Graham is going to be slightly late, and that's also why we are starting slightly late. And I do apologise to colleagues in the room. Sometimes it's unavoidable, it's always inconvenient, but thankfully David put on his Superman cape and sorted it all out by shifting the meeting slightly, so I'm grateful. So Graham will be along shortly. Declarations of interest, I have none. Does anybody have any pecuniary or other interests to disclose? No? Okay, marvellous. So the minutes then of the last meeting on the 20th of May, we need to receive and note them. I'm not sure there are any actions arising that don't come up in the subsequent items. Has everyone had a good read through, and does anyone have any comment? I'm going to take your silence as assent and that you're happy to note the minutes, so that's brilliant. Public participation. Do we have any questions or statements on the business of today's committee from town and parish councils or members of the public? David?
None received, Chairman.
Okay, I didn't think we did. That's marvellous. Right, in that case, we'll move on to the forward plan. And my app decided to fall over. Can we bring that up on the screen at all? Or is this for noting?
Yes, Chairman, I don't have that in my capacity, but I think once again that the things that will be brought up on screen are the things probably from the next item onwards, if as and when necessary by the director.
Okay, no problem. Sam's got his hand up, and I imagine he's going to say something similar.
Yeah, thanks very much. So, Chairman, I was just going to make the point that obviously when we're looking forward to November's board meeting, you'll see there's two items on there that we had to suspend from today's meeting just because of current service pressures. So I would like to bring forward a paper focusing on the health protection function. It's just important for the board to note that in peacetime, as it were, we wouldn't normally be providing this level of support to the regional health protection team. There are also the planned changes going ahead, which will establish the UK Health Security Agency, which takes over from Public Health England on the 1st of October. So I think November is quite a good time to look at where we will be as a local authority public health team then. And I was just going to also add that as we start to come out of the COVID-19 work, we will start to bring forward more items from the business plan. So expect further work on the forward plan for the January meeting.
Okay, that's really helpful, thank you. Okay, in that case, I consider the forward plan has been thoroughly noted, and we'll look forward to seeing those items coming forward. And it's back to you, Sam, for an update on general activities from Dorset Public Health.
Great, thank you very much. I'll just share my screen. So if you bear with me, I've got a short presentation. Just bring it up now. So if you could let me know when that's showing, that would be great. And it is, okay, great. Now I can't actually see people when I'm presenting, so if there's any people indicating that they want to stop me for questions at any time, I'm very happy to pause and take questions. Equally, I can't see the chat, so perhaps if someone could make me aware. That's lovely, thank you very much. So I just want to cover a brief situation update on coronavirus, and then I was going to focus on some of the key activity under the business plan that's happened since the board last met, and then we'll just wrap up by looking at the priorities over the next 6 months or so. And in the course of the presentation, I'll touch on our current health protection work. So this is the current situation. These two charts show the position with daily case numbers. They're not infection rates across the two councils. The third wave is very clearly underway locally, but it is mainly affecting 16 to 29-year-olds rather than our older age groups. And partly that's due to the success of the vaccination programme. We've done incredibly well locally with vaccinating. And if you look at the coverage in the older age groups, it's well in excess of 85%. And we continue to make good progress vaccinating younger people. But at the moment, it is very busy in the public health team. So we're seeing about 150 cases per day in the BCP Council area and about 90 cases per day in Dorset Council. So it's considerably affecting the public health team, but also the two contact tracing teams that work under each council. And we're seeing the number of incidents that we have to respond to ramp up significantly. So in the past week, when I put these slides together, there were more than 60 incident management teams held in relation to schools. It's getting very, very busy. Obviously, we've only got a week or so to continue to support schools, but it is important that we continue to try to reduce the number of children that are sent home as a result of bubbles that are told to self-isolate. So that work's really important, just going through and making sure that we're only asking children to self-isolate where they are definite close contacts of cases. Worth noting that hospital occupancy remains low, so there are 19 people currently in hospitals with COVID-19, very, very different to previous waves. But there is a rise in people that are requiring a bit of support at home through pulse oximetry monitoring. I think there's around about 26 people currently on that scheme. That's the pool of people, if you like, where if they deteriorate, they may well be admitted to hospital. So just looking at the hospital admissions alone doesn't give the full picture, but it is very, very much more positive compared to where we have been. The next slide shows the regional and national picture. Now, these are 7-day infection rates. And so the slide shows you the trajectory of how the infection rate has risen. BCP Council picked out in the blue, Dorset in the orange. And as you can see, we've also included some neighbouring councils there just for context. So Hampshire in the middle of the pack between BCP and Dorset Council, but we are not seeing infections spike as high as councils like Southampton, for example. And along the bottom, I've just put some comparison figures. So the Southwest rate currently is 279, compared with a rate of around 245 currently for BCP Council. England overall is at 343, but fortunately, we're not seeing the increase in infections as pronounced as some of the other urban areas in the Southwest. So Bristol is well over 500 cases per 100,000 currently, and Plymouth and South Gloucestershire both well over 400 cases per 100,000. So it does seem at the moment as if we have risen, but it looks as if we're plateauing a bit, which is really good news. So where are we now in terms of local COVID-19 work? Obviously, Prime Minister's announcement on Monday confirming that we will proceed on the 19th of July to step 4 under the roadmap. This will see the removal of legal restrictions on social distancing, the guidance and the regulations around making sure that workplaces and other settings are COVID secure is replaced by work safely guidance. And from August the 16th, another significant change, there'll be no requirement for people who are fully vaccinated or under the age of 18 to self-isolate, but they will still be advised to take a PCR test and just make sure that they are not infected with COVID. Positive cases will still have to isolate, so it's helpful to have confirmation that the test, trace and isolation system will continue. And there's a continuation of the self-isolation payments. They go until at least the end of September currently. But there are some significant changes affecting schools. So contact tracing and the bubble system will end in schools pretty much as schools break up. There's no longer a legal requirement to check into venues using the app, although it will be strongly encouraged. And there was the provision made within the regulations for directors of public health to reintroduce measures, but only in exceptional circumstances. So if we had particularly serious outbreaks, we would still have the ability to do that. At the moment, that is not yet clear, but I imagine it would be through escalation regionally and into the national bronze and silver meetings. So just a few points on health protection and the impact on the team. The day response team, as I mentioned in the first couple of slides, is very busy, and it is also very busy out of hours, mainly with multiple incidents from schools. We're working through what our responsibilities will be as a public health team as the restrictions are lifted. I think we've found that difficult in the past week, but we are reviewing the local outbreak management plan and trying to have discussions with different sectors to work out exactly what sort of support they will need, particularly as the guidance starts to change. My view is that although the regulations are lifted, the risk remains. So we are still saying to people it's important that those risk assessments are carried out, and the risk assessments will need to be done thinking through the different types of settings, the degree of inherent risk in the people that are in those settings, and also the risk to individuals. So if you think about the requirements to maintain mask wearing, they may be very different depending on the different settings. Healthcare, social care settings, I imagine, will still retain a very, very firm emphasis on PPE. But there may be some other settings where there is a bit of a relaxation. In terms of testing, we are still deploying our mobile testing units. Not only do they move around the county, but we've been increasingly using them to support outbreaks over the last couple of months. We have also revised the new community testing programme. So from the 1st of July, we've stood down the static assisted testing sites that were under each council, and we've replaced them with a range of agile and mobile units that can be moved around to support events, or they can also be used to support busy areas such as shopping centres as we see fit over the holiday period. The focus of the community testing scheme is going to be very much on making sure that we can offer assisted testing to people who are more vulnerable, who might not be able to order their test kits from pharmacies and online. But the rest of the adult population who we're asking to test regularly will be asked to either collect their kits from pharmacies or continue to order direct from the government portal. Just a note on vaccination, although we're doing really, really well, there is ongoing support that the public health team is providing to make sure that there are no significant gaps emerging. So that ongoing work around comms and engagement is considerable and really, really important. So making sure that we've got coverage as high as possible, particularly in younger age groups, is an ongoing challenge. I mentioned the local contact tracing work that continues under both councils. It's been great that we were a trailblazer under both councils to establish a new contact tracing system called Local Zero. That means that the local contact tracing teams take the cases with almost no delay from NHS Test and Trace, rather than having to wait for Test and Trace to make the first contact. So that change around has been really helpful in reducing the time taken to follow up. And they've both been achieving pretty high completion rates, but obviously that's coming under pressure currently as the cases increase. There's more recruitment happening under both teams, and we'll continue to keep the situation under review. The communications and guidance role will continue. It will probably become even more important as different sectors look to us for local guidance on what the risk is and what they should be doing. And we'll continue to be doing the Epicel modelling and providing that intelligence to system partners. In terms of our health protection resilience, we have used the Contained Outbreak Management Fund to bring forward the recruitment of a number of fixed term roles. So this is to support not just the health protection work, but also areas of the public health team that have had to join the day response team. So it's backfilling to support the ongoing public health work that still needs to happen. We're planning to continue that day response and out of hours teams, although we may well reprioritise work depending on how busy it gets. So if the team starts to become overwhelmed, we could see a situation where we would start to prioritise supporting incident management teams in response to the most high risk settings, and perhaps some of the simpler single case work would be left as less important and just provided with advice and guidance. It may well become much busier in the early autumn, particularly as schools return. And we're pushing for a national response around the longer term funding of health protection work under councils. So as the UK Health Security Agency forms, there's an ongoing conversation between myself and other directors of public health to say, could we move away from 1 year funding through pockets of money like the Contained Outbreak Management Fund and look at some more sustainable recurrent funding through the public health grant for health protection responsibilities. So as I've said at the beginning of the meeting, we'll pick that up in a paper in November as that starts to become clearer. But there's also the need for the Health Protection Board, which has been very focused on COVID-19, to now pick up other health protection issues. So as we go into the autumn, there's a sense that we're starting to see COVID-19 as just one of a number of respiratory viruses that we need to be vigilant for. So there'll be a focus on ensuring that the flu vaccination programme is as effective as it can be. Being vigilant for the first signs of flu and understanding the impact of other respiratory infections like respiratory syncytial virus, which affects predominantly younger children, but it is an important autumn infection that can be leading to some significant illness in younger children. The testing cell, just important to note that some of the key people we've had on secondment are now returning to their substantive roles in Dorset CCG. They have been absolutely brilliant in helping us mobilise the testing effort across Dorset and BCP councils. So we are working with both councils to make sure that we've got a single named person to assist with some of the operational issues when we're moving mobile testing units around. It's still an ongoing area where we're going to need some more support. So just the last couple of slides for me, I was just going to provide a little bit of a flavour as to what we've been doing under our business plan, which we shared with you last time. The main area of the plan has divided the work of the team into 4 sections, and the first bit focuses on our work supporting system work and recovery. Some significant progress has been made in the past couple of months on refreshing joint strategic needs assessment narratives. They're intended to start conversations about what our priorities should be as the ICS develops. We've completed a stock take of the Prevention at Scale programme, which will be coming to an end in its current form in the final year of the Sustainability and Transformation Plan. But as the integrated care system takes over from April next year, it's really important that we find the time and the space to hold a strategy workshop to look at how that work will continue. And we're continuing to contribute to the integrated care system development, and particularly the work streams on commissioning and place-based partnerships. COVID-19, I've covered in quite a lot of detail. I've mentioned that we're doing a stock take against our local outbreak management plan. There is going to be a new contained strategy written off the back of step 4. So we're awaiting further guidance as to see what the responsibilities of councils will be. I've talked about contact tracing. I think that requirement will continue, at least in the medium term. And we're continuing to think through how we can make the most effective use of the Contain Outbreak Management Fund. So thinking through investments for 21-22, we're going to focus on ensuring our communities that are most affected by COVID-19 are continue to be as resilient as they can be. We've got surge testing plans in place under each council for variants of concern. They have been exercised in Dorset Council, and I believe the BCP Council exercise is taking place next Tuesday. So that's an ongoing area that we will continue to support. And I've talked about the community testing programme already. Just a final note on our organisation. So this is our internal work around Public Health Dorset. We've completed the redesign work, and we are likely to begin consultation on moving to a single set of terms and conditions from mid-July, with the implementation of that new structure and the new terms and conditions from mid-September onwards. And then final slide from me, just looking at the sort of priority work over the next 6 months. In terms of system work and recovery, it will be continuing to identify those developing priorities for the ICS, making sure that population health management and JSNA is embedded in the new functions. We'll continue to develop the health inequalities interim strategy, working with NHS colleagues, and continue to ensure that the long-term plan funding that's coming to the system is being made best use of. And there have been additional investments announced recently on smoking cessation in hospitals, and also some new funding for healthy weight. So I suggest in November we perhaps highlight how that money is being used, because obviously it's really important that that's done so in a way that's as joined up as possible. But it's good news that we've got a little bit more money for prevention into the system. In terms of COVID-19, I think we'll see a shift towards protecting the most vulnerable. So we'll be thinking through how we can continue to support the most high-risk settings, ensuring good vaccination coverage, preparing for the booster programme in September, and there'll be an ongoing surveillance response required, not just for COVID-19, but also variants of concern. I've mentioned the work in our organisation about making sure that we complete our service redesign, but I think one of the things I'm really keen on is that we don't ignore the recovery and the well-being of the wider public health team. So there is some continuing professional development planned. We're going to look at what makes us resilient and strong as a public health team, and particularly making sure that we're not continually cycling in and out of major incident mode, but we can approach this in a calm and planned way. It's much better for people's mental health, I feel, rather than being stood up and permanently anxious about some of these issues. We need to look at our induction for people coming into the team on the fixed term roles, and we will complete the business planning and prioritisation process and share that with the board. And in terms of programmes, we're going to talk later on in the meeting about reviewing the NHS Health Checks delivery model. That'll be really key this year. And also look at how we increase our weight management offer in relation to the new money that's coming into the system, as just mentioned, and deliver the Live Well Dorset service plan, which has got a bit of recovery to do. We saw attendance and participation drop a bit during the pandemic, but they are now raring to go, and they've just completed their service planning for the next year. So that's all I intended to show today. I will just stop sharing my screen. Bear with me a second.
Brilliant.
Hopefully that's down. Happy to take questions, Chairman.
Thanks, Sam. I think you know, I always find it really reassuring your updates, and I think particularly moving into that place of resilience and the use of the contain outbreak management money is particularly reassuring. And I think that recognition that you don't always want to be on the defensive, you don't always want to have people constantly standing up, standing down, and that recognition of the effect that it has on people. So I find that particularly welcome. Has anybody else got any comments on Sam's update? Nicola, Councillor Green, would you like to come in?
Yes, thank you, Lauren. Thank you, Sam. I think for anybody who didn't understand or who hasn't given much thought in the past to what public health is about, Sam's presentation has been, as always, incredibly clear from start to finish of what public health is all about. And I suppose I just wanted to note, perhaps from the board's perspective, that all those people who have been doing all those things have busy day jobs. We talked quite properly about the role of public health in through this period of the pandemic, but the work that has been undertaken in addition to all that really vital stuff that they do in any case around prevention at scale, suicide prevention, supporting well-being through this period is really quite remarkable, and therefore I would like to remark upon it. And if it's possible, on behalf of the board, to thank through Sam and extensively through Sam's leadership, the whole board for the amazing way in which they've responded and given our population reassurance, assurance, somewhere to go to. Support for schools and businesses has been very, very welcomed by all stakeholders and by our residents as a whole. So I just wondered, Chair, if it would be appropriate for us as a board to record that and ask that Sam take forward our very warm thanks to the wider public health team, and of course to the communications team, which has gone alongside that, because it's been the warn and inform to our residents has been an absolutely crucial part of giving people the assurance and the understanding about what's been happening through some immensely worrying and troubling times.
Yeah, I think it would be more than appropriate, and I think you've summed it up incredibly eloquently. So yeah, Sam, please do pass on our heartfelt thanks to everybody that's been involved, as just outlined. Absolutely brilliant work, and I think these reports really do help to try to get that across to the public, just how much goes on. So thank you. Any more comments before we move on? Okay, well, and in that case, I'll just say thank you for that again, and we'll move on to, gosh, it's another report from Sam, the recovery of prevention services for NHS health checks and community health improvement services. So Sam, I hope you got a drink of water because you're going to be talking a lot today.
Yes, I've got a big drink of water on hand. So thank you very much, Chairman. I'm going to sort of take this in two parts, really. The main information in the paper sets out the current position in relation to the recovery of our community health improvement services. I think it's really important to note that these are services, they're largely prevention services, but they're commissioned from primary care and pharmacy, and they cover a huge range, really. Includes smoking cessation support, sexual health and drug and alcohol harm minimisation services. So things like long-acting contraception, emergency hormonal contraception, needle exchange, supervised consumption of opiate substitution therapies. So they are often sort of wraparound services, if you like. They go against our main sexual health and drug and alcohol service delivery. No surprise that during the pandemic, the services had to think quite differently about how they could be delivered. So there was thinking done about ways that could be done safely, reducing face-to-face contact. They are, on the whole, mainly back in recovery mode and starting to deliver those services in a normal way again. The bit that I really wanted to talk to the board about today and to spend a bit more time on in the paper is discussing the first thoughts about the recovery of the NHS Health Checks programme. So that was the one programme where it relies on face-to-face risk assessment. It was a huge programme, so it was mandated by the Secretary of State for Health when Public Health Services came over to councils, and in its purest form, the guidance said that councils must deliver a programme that invites the whole of the population aged 40 to 74 once every 5 years for a regular and routine assessment of their cardiovascular disease risk, which added up to some big numbers. And the way that we've run the programme in the past is really in two parts. There's an invitation part where we ask primary care providers to write out to everyone who isn't known to them on a disease register, and then invite them for that risk assessment. And as a consequence of that, depending on what your risk assessment says, you would then either be given some very general health improvement advice, or if you crossed the threshold where there was concern that you might have early signs of cardiovascular disease, you'd then go off into a primary care diagnosis part and assessment for treatment. So when the pandemic happened, all of that face-to-face delivery was paused. And the next thing that happened was that in November last year, the Secretary of State for Health, as was, Matt Hancock, basically said to councils the requirement to run this as a universal service no longer stands. So there was some subtle changes made to the regulations, which mean that we can now start to think about a slightly different model. So rather than prescribe that, what I've done in the paper is to just try to set out some of the ideas that as we go through the next period of engagement and working with communities and other providers, just start to think through how we could do this quite differently in a way that might resolve some of the challenges. And in a way, it's an ideal programme to test our aspirations as an integrated care system. So I personally would like to see this looking less like a Public Health Commissioned siloed service and something that resembles more of an integrated approach to helping people understand their risk around cardiovascular disease, and then an appropriate sort of response, if you like, which is developed with people rather than it being a sort of biomedical approach, if that makes sense. In the past, there's been quite a lot of focus on measuring people's risk factors and their numbers, and as important as that is, it can put some people off. We've had a sense that if you're a regular smoker, or perhaps if your weight isn't where you might want it to be, there are lots of people who don't want to go to their GP surgery just to be told that, and then to receive advice that they may not be ready to act on. So I think there's lots of opportunity to think about this differently. The challenges of the programme are that it's been consistently difficult to deliver, particularly in areas where we've had higher rates of cardiovascular disease. So we've usually seen better delivery in areas with lower rates of cardiovascular disease, and it's been harder to do this in areas where there perhaps have been practices that have been under a bit more pressure, usually more deprived areas, but those are the areas that we really wanted the programme to work in. And we've never had consistently strong delivery. So I think it's also important to note that primary care is currently under quite a lot of pressure. They've got a lot of catch-up work and recovery work to do, as well as being flat out in many instances with delivering vaccinations. So it's a good opportunity to pause and to rethink how we might see the programme be put back together in a different way through the integrated care system. So I've set out some ideas in the paper. I think the most important of these are the idea that we could improve our digital approach. So the risk assessment doesn't necessarily need to be done in a face-to-face setting. We could develop an online tool that would give most people the important things that they need to know about their risk. But I think there's also opportunities to start a conversation about the role of people and communities in understanding what actions they can take to reduce their risk of cardiovascular disease, and potentially a big role for the third sector. So there are some areas of the country where organisations like the British Heart Foundation have played quite a big role in local community campaigns around the importance of knowing your blood pressure or knowing your cholesterol number. So those are just some of the initial concepts that we would like to start to have a conversation about, with a view to firming up a commissioning model over the next year. So that's all I wanted to say in relation to the paper. I'm more than happy to take questions, and I've got a colleague standing by in case there are any particularly tricky technical questions about community health improvement services that I may not be able to answer.
Brilliant, thank you, Sam. Yeah, this is really interesting, isn't it, colleagues? Because your point about the digital offer, and I know that you see on social media all the time something will pop up and say, take this test, or and a lot of people use them for sort of quite frivolous reasons, but actually there is something about a trusted partner providing that. And that people can access it in that relatively informal way from home, from their phone if they're out and about, or but knowing that it's not some sort of spam organisation. So I suppose a trusted statutory body offering that informal engagement is something that I think I would support. Colleagues, do you have views on this at all? Yeah, Nicola.
Thank you. My views are their views rather than an informed approach. But I just think the way Sam set it out, I think the way I'm thinking is there has never been a better time to be having this conversation. We've been forced over the past 18 months to embrace some digital approaches to things that we didn't think a digital approach might be the right way to. But there's been some immensely successful ways of engaging with health through digital means, or at least through digital triage, which I think is probably any medical person would probably pick me up on my use of language, but I mean it in a very non-specific way. But actually to be doing some screening, which is what some of this could apply, and to be ensuring that people who don't need interventions aren't pushing forward to get them out of a genuine concern, actually to allay fears, I think would be really helpful, because there is no sense that just because you've your digital screening says things are fine, that you don't need to carry on being careful and taking care and so on. But I think as a first step, that would be very welcome for a lot of people. The community approach I wholly endorse. I think that's absolutely vital, and particularly working with our priority communities where we've not had the best reach. I think is where there are immense gains to be made, and again through the work that has gone on as a result of the pandemic and the Trusted Voices law, I think, to which you were referring, to use the reach that public health has into our communities, whether geographic, ethnic-based or age-based, all those different things. That the multi-layering of that sort of targeted approach has been really, really helpful. And I'm glad I mentioned the communication team earlier, because that has been enabled by some really well-informed and targeted communications and based on behavioural insights as well. So again, I think that's a great approach, and that there should still be a general offer. Yes, absolutely. Everybody should feel welcome to it. But and as people need more targeted support, so be it. But I think the stopping and thinking about it, and rather than saying just because you're within a particular age group, you should go through the same process with no assimilation of what those risk factors are, is perhaps not the best use of resources, scant resources that we have. But I also think, I keep mentioning in every conversation with Sam, it seems, the immense role that our community pharmacies have to play. So, if there is other outreach that they can do, and I play real credit to them over this period as well, and the backup they've given to the primary care network, or I suppose they are part of the primary care network, back up to GP surgeries and embracing our population, providing support to our communities. I think they're probably a crucial partner in this as well. So yes, I would love to see more development, but I think the approach and the way, the direction of travel is exactly what we should be looking at.
Brilliant, thank you, Nicola. Very good points actually, with which I entirely agree. Karen, did you want to come in?
Well, I did, thank you, Laura, but I haven't got much to say now because Nicholas said some of what I wanted to say, which is I absolutely support the digital approach. I think it's great, and as you say, Nicola, it's there's never been a better time. We're all far more used to using digital means now. I suppose I'm slightly concerned about people with some additional needs, people with a learning disability. How easy would they find it? Would they sort of use something like that rather than and perhaps not be able to use it correctly rather than actually be able to go and see somebody? So that's a slight caution for me. And the bit about pharmacies, that's exactly what I was going to say. I think the pharmacies that offer that blood pressure monitor within their area, you know, the public area, where you can literally just go check your blood pressure, you get a printed readout and you can show it to the pharmacist and say, hey, is that okay? And they go, maybe not, or yeah, that's okay, but keep checking it. And if that could be expanded, I think that's really good, because most people do go to the pharmacy to collect their prescriptions or something, and those are perhaps the people who need prescriptions, who need to have that continuing check on their health. But yeah, let's help people take responsibility, and let's do that early intervention, because we will absolutely reap the rewards in years to come. So yeah, fully supportive. Thank you.
Brilliant, thank you, Karen. Vanessa, you wanted to come in on this one, and then Jane.
I did, thank you, and thanks, Sam. And I probably agree with everything that people have said before. I think a blended offer would be really helpful. It would mean that people that have different needs in how they prefer to access or how they can access things would be appreciated. I think one of the concerns that I have is there hasn't been a service, and I just wonder about the impact of not having had a service, and therefore how soon would we be in a position to start up some of the offers? How do we make the decisions about what that might look like? So more of a sort of practical question of how would this move forward, really, Sam?
Oh, that's a good question. So I think there's something about being very, very clear with the timescale and the plans. I don't want to foreshorten the amount of time that it might take to do that co-production side. But at the same time, I think what would be interesting is whether we could get a digital offer up and running fairly quickly as an interim position. So we'd say, you know, if you are concerned, here's a risk calculator you can access online, you can plug your numbers in. And yeah, Sophia's posted in the chat bar, Live Well Dorset do some health check MOTs, but it's probably not at the scale of the former health checks programme. So there's a number of elements that we need to check in with. I think we need a conversation with primary care networks about their expectations around what they feel able to deliver over the next year. Definitely the role of community pharmacies, I think, is worth revisiting and exploring again. We have commissioned health checks in the past from community pharmacy, but it's only been around 10% of the overall delivery. The bulk has been through primary care. But I think the next steps for me would be to work this up into a proper timescale leading up to the bits that need to be formally tendered. If that's the route that it goes down, we'll have a timescale for that. But I'd like us to get to a position where this is seen as a locality conversation, really, and to develop ownership around the issue. So what I'll be saying to localities is, what resources do you have on hand? What assets do you have that could form an ongoing discussion about how you're going to identify the people in your neighbourhoods that really could benefit from this different approach? So getting ownership rather than just inviting people to a programme that they may not really feel that they've got much engagement with, I think will be the thing that really makes a difference. But perhaps by the next board meeting, if we can come back with a little bit of an indicative timescale, particularly around the digital offer, I think that would be really helpful.
Thank you, Sam. Yeah, that would be helpful. Jane, did you want to come in? Your hand's up.
Yeah, so this was in response to Councillor Rampton's comment about learning disabilities. So they're alongside the NHS health checks, which is a public health commission thing currently. There is also annual health checks for people with serious mental illness and annual health checks for people with learning disability. And I know that Live Well Dorset have done quite a bit of work together with the team that's kind of delivering the annual health checks for serious mental illness to try and make that a bit more of an integrated offer. And, you know, that covers a lot of the same areas as the health check. It's not exactly the same as a health check, but covers a lot of the same areas. And I know that they are hoping to do a similar thing with for people with learning disabilities and looking at the resources and things that they would need for that. So just to reassure you that that is something that is on the that we're on the radar.
That's brilliant, Jane. Thank you, and that is reassuring. So thank you everyone for your comments. I think, Sam, you're gathering that we're quite in favour of this. Please do take it forward. Please do give us an outline. I think we're all very supportive, and it sounds like a really good way forward. Taking some of that learning from what we've all been through the last couple of years.
Thank you very much. This is a really helpful steer.
Fantastic. Thank you. I think we're on to finance now. I've lost ModGov. It keeps falling over. So forgive me, I keep losing my agenda. Yes, we have got the finance update next.
Thank you, Chair.
Little drink. That seems very reasonable. You are doing a lot of talking today. So do you want to walk us through the finance update, Sam? Thank you.
I think I'm going to do it, Laura. Thank you.
Oh, of course you are. You've even popped up with finance next to your name, and I know so I apologise.
No problem. Thank you. So today's paper is for noting. I just wanted to draw your attention to a couple of areas. So the current forecast outturn is £146,000 underspent. This is now based on 3 months worth of activity data and taking into consideration the COVID impact. So there is potential additional costs for long-acting contraception as normal service resumes and backlogs are managed. Supervised consumption and needle exchange costs have changed to reflect that there has been a shift over to BCP contracts. Smoke cessation activity through GPs and pharmacies is assumed to continue at the same level. And there is expected to be a small spend on NHS health checks during 21-22, but this could change and will be monitored throughout the year. So the second bit was around the retained amount. So each authority retains amounts from the public health grant each year. Each council has an additional £500,000 this year, and currently these costs haven't got detailed plans, but we hope to bring those back in the November Joint Public Health Board. So that was it, really, a short paper this month.
Thank you, Sean. Short but important, and yeah, looking forward to looking at some of that detail in November. Yeah. We're going to be quite busy in November. So we need to note this paper. I don't know if colleagues around the virtual table have got any comments they want to make, or if we're happy to just note the financial position at this point. Nicola, did you want to come in, or was that just a jaunty way?
Nod of assent. Yes, thank you. Happy to note it.
Fantastic. In that case, got a note from Karen. Brilliant. So thank you very much, Sean. Very happy to note that. And then we're on to the clinical services performance monitoring, which is item number 11, and our final item, because I don't think we have any urgent items today. So Sam, if you'd like to take us through that, please.
Chairman, thank you. If it's okay, I'll introduce it very briefly, but I think I've got colleagues from BCP Council, Phil Hornsby. The most important thing to note since you last saw the clinical services performance update is that the responsibility for commissioning the whole of drug and alcohol services for BCP Council's now shifted to BCP Council. So I'll invite Phil perhaps to come in and pick up any points around performance in the BCP Council area. And I think is Rob on the call today as well?
Yeah.
Great. So Rob may want to pick up some of the more detail around some of the other issues flagged around the Dorset Council service performance, but I'll just open with some sort of general notes, if that's okay, first of all. So it is the first report since the transfer of commissioning. It was a piece of work that was done really well, actually. I think that the transition was smooth. The Joint Public Health Board will retain oversight of all of the performance metrics, which is why we'll continue to see performance information around both services, and that's because of the statutory responsibility of the DPH. So this is the one place where we'll be able to question performance if we feel it's not where it needs to be. Just some issues that I think have been raised in the paper in relation to BCP that I'm interested in. I think it's really important to keep an eye on the number of opiate users in treatment. To some extent, that's a victim of the success of some of the new pathways that have been started. And the paper talks about the success of the connection with treatment from people who've been homeless and also people identified in hospital who are homeless. And it's going to be important to ensure sufficient funding for that service going forward. So that's one area that I think it'd be really important to keep an eye on. The other issue that we do need to keep noting in the board is the position in relation to drug-related deaths, which have reduced slightly this year, but they are still a concern. It is a national issue, it's not just a local issue, and the paper flags that we need to continue to do more work on the provision of naloxone. And I believe at the moment that other providers, such as housing providers, cannot issue that medication directly to people who may be in their accommodation. But that's an ongoing conversation, I think, across our local system. How can we get naloxone to the people who may benefit most, as quickly as possible, not just through formal drug and alcohol services. In terms of the Dorset Council issues, we've noted that there's been a reduction in people presenting for treatment for drug misuse. And although the performance around alcohol treatment is similar to national, the completion rates have fallen. So it's going to be important to monitor that over the next year and see if that recovers. And we've also noted the impact of the pandemic on testing for bloodborne viruses and concomitant hepatitis B immunisation. There's also been a fall in the number of young people presenting for treatment. And so the providers currently exploring what might be the reasons for that. Are there particular barriers? And hopefully they will come forward with a plan that looks at improving access to treatment. But I think it will be important to monitor that over the next year. So the board needs to keep an eye on it. In terms of sexual health services, my general comment would be a lot of this is continuing to monitor the implementation of the new service. So we recommissioned and retendered. It is actually a really good example of a provider collaborative. So the ICS legislation is going to talk about the importance of provider collaboratives, but people may not realise we already have them in place. So this service is now provided by Dorset Healthcare, working in partnership with both acute trusts. And actually, I'm really pleased with the progress that the service has made, because it's taken a long time, but they are finally a proper community service. And you can see they're managing to maintain good performance. And they've developed a couple of useful and interesting services in the past year, not least the new service for pre-exposure prophylaxis for HIV. So through the public health grant, last year we received a small uplift which enabled Dorset Healthcare to develop that service. The prescribing costs are paid for by NHS, but we received money through the grant to enable the provider to fulfil the management costs in relation to that service. And the paper notes that there is a risk that demand for that service could grow quite considerably. So it's being introduced in a phased way, but we're into the start of the second year and so far so good. If it's working really, really well, it can be a really important plank in all of the interventions that are on hand to try to reduce new HIV infections. So it is important that we continue to get that right. I think the other thing that I'd pull out for board members' attention is the work in paragraph 3.9. So Dorset Police are leading a review at the moment of education provision in schools, and the Children and Young People Service have been working closely to identify priority schools where Sexual Health Dorset will support with more targeted sexual health education. So they don't provide a core offer universally, but they still go into the schools where the risk to young people is considered the highest. And we'll just keep an eye on that review as that starts to work its way through. But I think there'll be a really big focus on that over the next year. And of course, the Police and Crime Commissioner is very, very supportive of looking at that type of provision in schools. So I don't have any further comments, but I'd invite either Phil or Rob to pick up on anything in more detail, or Sophia from a sexual health services perspective.
I'm okay. Do you mind if I? Oh, sorry, Sophia, I see you've got your hand up. I won't. I'll let you go first.
No, Rob, I'm happy for you.
Okay. I was just, hi everyone, nice to see you all. I was just going to add that as we picked up our surveillance of drug-related deaths over the past kind of 18 months, and as Sam alluded to, we changed our whole way of delivery of that. As we kind of continued that surveillance, we started to look at alcohol-related deaths as well within our kind of treatment services. PHE just released some data just a couple of weeks ago that said the increase in alcohol liver disease from 2019 to 2020 is about a 21% increase of that, which is pretty unbelievable, actually. The best way it's been described to me is the gap between a lot of people's last coffee of the day, a first glass of wine, has considerably narrowed over the past kind of 18 months within one demographic, and within other demographics, alcohol-related issues have hit those that are most vulnerable in our society. Along with that, we're keeping an eye on alcohol-related hospital admissions, and then next month, Public Health Dorset, along with BCP Commissioner colleagues Karen Wood, members of the CCG and the ACEEPs are getting together just to talk about whether we do need to introduce some kind of alcohol-related death panel, which would run similar to the drug-related one. But obviously, it's just a real kind of starting point of that conversation. So I think the thing to keep an eye on would be probably more so than the opiate stuff, which is kind of out there. There is a feeling that there's a hidden alcohol problem which has arisen specifically from COVID. So I think it will just be mindful to see how that moves in the future, really.
Thank you. That's really interesting, and definitely an area that we should be monitoring. Sophia, did you want to come in?
Thank you, Chair. I just wanted to say sexual health services initially, because of redeployment due to COVID, we had to, move around and be flexible, but recovery is going really well, and we are back to normal as the data looks good. We're going to review the year one education at the end of year one of the contract, which will be October time. So I'll be happy to feed back where we are there. And part of our quality assurance, one of which will be doing a deep dive with the schools and education and where we are with recovery and contacting the priority schools. So again, I'd be happy to feed back to the board once we've done that piece of work.
Thank you. I think that's very welcome. Okay, fantastic. Are we going to Phil now, or have we kind of covered that? We've covered that. Does anyone have any comments on what we've heard today with regard to this? I think the areas of focus seem very sensible and certainly supportive of the school's contract and really having another look at that and some feedback on how that's working in the autumn. I'm not seeing a deluge of hands going up. Are colleagues happy to note? Okay. You're happy to note? Fantastic. Okay, in that case, Sam, thank you, and colleagues, thank you. Noted, and general direction of travel supportive of, I think we can take from all of the items today. We don't have any urgent items, do we, David?
No, we don't, Chairman. No, I was just going to say, though, at this juncture, our next meeting is Thursday, the 18th of November, and of course we'll be back in-person meeting. So I think I'll propose that to be held at Poole somewhere. Well, I say somewhere, probably the Civic Centre or the like. So I thought I'd just make mention of that.
Thank you, David. That's a really good point, and let's hope that we are back in person, because I think it would be good to return to some sort of normality. We will iron out the details, I guess, of that meeting in due course. I say we, I mean David.
Yes.
So,
and might I also just say that the opportunity for the press and public to view what is happening, rather than necessarily being there in person, of course they will still able to be there in person should they so wish, but the council is accessing a webcasting system. So although it won't be done through Teams like we're doing now, my understanding is that there will still be the ability for public to have access of proceedings through a webcast. So I just thought I'd say that.
yeah, that's really important, David. I know we've had some really good uptake in engagement because members of the public have been able to just sit on their sofa and attend a meeting. My mum tends to come to some of my meetings, which is slightly embarrassing, but it's very nice that she's able to engage in that way rather than driving all the way across the county. I don't think she's missed one, but we never know. But it is an important point about engagement, and I'm really glad that we are able to continue with that hybrid model because I do think it's really important. So thanks for that, David. That's a really good point. Thank you everybody for attending today, and thank you particularly to Sam and your teams for what is always a reassuring and positive update, and I will let you go about the rest of your day. Thank you very much everyone for attending.
Thanks everyone. Bye.
Bye.
Thank you very much all. Thanks. Bye-bye.